Right.
Have you had any of your sessions hijacked before?
No.
Okay, brilliant.
No. Can I, Marcia, you don't need to say anything, but I know you're online. I'm just going to ask you to try and help us manage the chat. We're going to go through question by question when the time comes. Okay, so we're going to kick off now, and can I welcome everyone to this session where we're looking at the COVID-19 vaccines, at least the ones that are available in the UK, and to have your questions answered. We have had a few sessions. My name is, I'm from the Watford African Caribbean Association. I'm the chair of the association, if you don't know. We're an association that have been present in Watford since 1976. So if you didn't know before tonight, you now know. And we have a membership system. Membership is free, and I will encourage you all to consider becoming a member. Our motto is together we can achieve. Together we can achieve. And actually, what I think COVID and other stuff that's happened recently have illustrated is the importance of us being together in seeking to make a difference and to develop our community. So we are about looking at the well-being, particularly of our African and Caribbean communities in and around the Watford area. So welcome everyone. We have as was said in the advert, we have a number of local doctors who have volunteered to come and spend their evening with us, answering questions that you will undoubtedly have. So the way we're going to manage the session is that I'm going to ask our doctors to just introduce themselves and say a few words, after which we're going to open it up for your questions. I suggest that if you have questions now, you can do one of two things initially, because they're going to be talking. So you might just want to put something in the chat, and there's a chat function. You'll see a question mark at the end of at the bottom of your screen, and if you click on that, it allows you to type in questions. There's also, of course, the option to put your hand up, but I would suggest that whilst you're waiting for them to conclude their opening remarks, could you mute when you come in, please? Whilst you're waiting for them to complete their opening remarks, rather than forgetting the questions, just type it in the chat if you can, and then we'll pick it up. So once again, welcome. So I'm going to ask, as I say, we've got Dr. Charles Esene, Dr. Pearl, and Dr. Obi with us. So I'm going to ask them now to just introduce themselves and to say a few words to you, and then we'll open up to the question and answer session. So who wants to go first?
Ladies first, Pearl.
Good evening, everybody. Thank you so much for coming. My name is Dr. Pearl Onyekuru. I'm a GP. I'm a GP partner in a local practice called Vinehouse Health Centre in Abbots Langley. I've worked as a GP since 2006, and I've worked in medicine for a lot more years than that. I'm here to, support my colleagues. I'm also part of the AfroGP Herts group, and we are a group of local GPs that work and live in and around the Hertfordshire and Bedfordshire area. And we have come together to support our community, to answer your questions, and to and to allay your fears. And if you have any things you want to discuss, then please bring them. Thank you.
Obi?
Yeah, hi everyone. Thanks, Clive, for the introduction. My name is Obi Ezeuko. I'm a GP in Stevenage, and I'm also a member of the AfroGP Hearts and Beds group. It's a pleasure to be here, and I'm happy to take any questions you might have about the vaccine. I've taken the vaccine myself. So, it's nice for anyone to have concerns, but that's why we're here. We're here to address all I have. Thank you.
Hi, everyone. My name is Dr. Charles Esene. I'm a GP as well. I work across both Bedfordshire and Hertfordshire. I'm originally from Nigeria, and I'm the chairperson of the AfroGP Herts and Beds group, which, as Pearl said, is a collective of GPs of African origin. And we're here to answer your questions. We know you do have questions, you have concerns, and then we're here to support you through that process. So thank you very much for having us.
Okay. Can I ask you, please, if you're not speaking, if you could mute your microphone? I mean, I can do it, but actually it's easy if you just mute your microphone. So we'll just, anyone who is actually speaking, just have those people, because otherwise it'll be a bit disruptive. I'm just looking at, so we're now going to open up for question, but I mean, just to say that we do have representatives from the CCG with us. So Lynn, I don't know if you want, sorry, not the CCG, the Clinical Commission Group, the CCG. Lynn, did you want to say, introduce yourselves?
Oh, thank you, Clive. My name's Lynn Dalton. I'm the Director of Primary Care Commissioning and Contracting for Herts Valley CCG, which covers the West Hertfordshire area, and also 2 other CCGs. And I've also got my colleague with me this evening, Lynn Talbot, who is the COVID vaccine lead. Lynn would like to introduce herself.
Yes, I'm Lynn Talbot. I'm the project manager across the ICS, that's across Hertfordshire and West Essex for the COVID vaccine programme, and concentrating on health inequalities. So this is particularly close to my heart.
Okay, so does anyone have any questions? I mean, I do have 1 or 2 myself, but this was really your show. So if you'd like to put, there's not in the question as yet, in the chat as yet. So, but if you do have a question that you want to ask, then please put your hand up if you're happy to do so, and we'll get you to ask the question. Okay, should I just say I've seen that we've just been joined by our Director of Public Health in Hertfordshire, Professor Jim McManus. So Jim, I don't know if you wanted to say hello too before we get into the question. I don't know if you're in as yet, Jim.
Hello. Yes, I'm in. I've had a wee bit of issue with Teams and Zoom this afternoon, and my system decided it was a really good idea to pick to upgrade at around 5 to 6, which didn't do my blood pressure any good. I just want to say thank you for organising this. Thank you for doing it. The latest vaccine figures suggest that even more people are taking the vaccine, including people from Black and Caribbean and a number of Asian populations. And we have higher uptake, particularly in our Black populations and our Asian populations, especially Pakistani, Bangladeshi and Indian than London, and that's really good. I had my AstraZeneca vaccine 4 weeks ago this Sunday, and I fully intend to have the second vaccine. So I'm confident the vaccine is worth it, safe and effective. And I've had it myself, and I have my other one. Really pleased that you're organising these webinars to kind of answer questions. And if there's anything I can help any of you with in terms of supporting people in any way to get the vaccine up, I'd really like to do that.
Okay.
It's really important, and I'll shut up in a second, I promise, that we get as many people vaccinated, because the people who bore the highest toll of death during the first and second waves were Black people, Asian people, and people from other minority ethnic populations. The other populations who take up the vaccine least, they will be the populations who will have the highest burden going forward. And we can't have that, because it's just unjust. So anything I can do to help, and thank you to every one of you for doing that. And thank you for inviting me to say a few words. I'll shut up now.
Thanks, Jim. Okay, we do have some questions, so please keep them coming. I see that we've got 44 people in this session at the moment. So I think the first question I can see is, it might be one that you partially are best able to answer, Jim. I'm not too sure, because it's, what is the current uptake of BAME community statistically in beds and Herts area? I know you're for Hertfordshire. I don't know if you also know anything for beds. I don't know if the doctors know this this information either. Jim, at least you know Hertfordshire. So can you say what the position is?
I'm just trying to get the dashboard to talk to me, so we know that it's gone up in the last week, and that we had, our white British population was at 64%. Our Indian population was, and the servers decided not to reload. Just give me a second, and I'll get this up for you so that I'm quoting chapter and verse at you.
Jim, whilst you're doing that, just to make best use of time, there's a second question which maybe the doctors can answer, which is, what are the reasons for the hesitancy, I presume, from the BAME community, to the extent that it exists? Any ideas? I don't know who wants to pick that up.
Let me pick that up. I think there are several reasons why people will be hesitant to take the vaccine, especially people from the Black community. And these are things that we've been trying to look at as a group of Black doctors as well. And one of them is the history of mistrust. So generally, based on the history, on the antecedents of the past, Black people are a bit skeptical when the government offers them things, because they've always felt that probably there's a reason that the government do not care about them. So that is one of the reasons, most likely, that people are not coming forward to have the vaccine. There is religion as well. So we've got a lot of religion that initially were against the vaccine. But what we are beginning to see now is that we're seeing more imams, more gurus, more priests coming out in favor of the vaccine. So that's beginning to affect the figures that Jim is talking about. So we're beginning to see an increase in the uptake. But those were the reasons for the initial hesitance. And then whilst the government was busy, heads down in the lab with the scientists trying to create these vaccines, a lot of misinformation had gone ahead, and that was beginning to affect people's uptake. Even some of the jokes about the vaccine, some people took quite seriously. Now we're beginning to claw all that back with a positive information to let people understand that the vaccine is safe, it is efficient in curtailing the virus, and we're beginning to see the numbers. At least now people are beginning to go out a little bit more freely. England or the United Kingdom is opening up because of the vaccine uptake. So we're beginning to claw back that negative information. Generally, people also are very cautious. It's a new vaccine. They don't know much about it. They want information about it before they step forward. Now we're coming out with information about it. Where we don't know, we say we don't know. What we know, we tell them we know. And that is beginning to increase the uptake. So those were the reasons for the hesitance in the first instance. But we're beginning to claw all that back. The misinformation, the religion, culture as well. So now we are at that point where we can start to build our head of steam. People can see soft data is showing that taking the vaccine also is suppressing the transmission. That's very good for people to hear. So we need to still talk about the positivity of the vaccine rather than focus on some of the negative things that might come with the vaccine.
Okay, thank you very much. Jim, have you got that information now?
I have indeed, and I completely agree with what Charles has said, is that because there wasn't a lot of information out there, the misinformation filled the vacuum. But we've seen, in fact, last Saturday, there were a group of Black clergy who had a webinar for people. So for white British, it's 64%. For any other white population, it's 40%. Indian, 52%. African, and these are people, the ethnicities that are recorded at the point of vaccine that people give themselves. African, 41%. Caribbean, 42%. Any other Black, 40%. Pakistani, 41%. And Bangladeshi are the same. And any other region of 48%. So our gap is nothing like as large as between white and Black populations as the gap in London. But I would also say that our gap has narrowed. So the uptake in Black communities has gone up by 6% in the last week.
Okay. Thanks for that, Jim. Just a quick question. That 46%, that 40 to 42% is of the population as a whole, or just the relevant population?
So that's the people in 1 to 9 who are eligible for the vaccine.
Okay.
So that's from people aged 85 and over, care workers, healthcare workers, right down to people aged. But actually, the uptake in healthcare workers is over 80%.
Okay. Okay. Thank you very much, Jim. Okay. So Marilyn has actually got her hand up. So I'll continue with what's in the chat. But Marilyn, do you want to just ask your question because you put your hand up?
Yeah, absolutely. And I'll probably start with a disclaimer on your behalf. I recognize you're not going to be giving medical advice. You're not going to be giving legal advice. But Clive had asked the question also, and it's one that comes up a lot. What is the reluctance? So for myself, I have a medical condition. The only reason I have this condition is because of an NHS kind of blunder and taking a treatment which was supposedly tried and tested, should have been very straightforward. And it left me with a range of health conditions which I've struggled with for the past 25 years. Having looked online to see how this vaccine will interact, all I can find, and I've checked the government websites, I've checked all over the place, and this is basically the statement. We wait the full publication of the trial results to find out in detail about how patients with this disorder have been studied in these trials. So basically they're saying they have no idea how it's going to interact. So having already suffered for 25 years, I'm not rushing forwards until I've seen some real data. So for people who need data, what are your thoughts about that?
Sorry, can I come in there?
Yeah, yes.
Hello, hi, yeah. So thank you so much, Marilyn, and thank you for your question. And I think when it comes to, now, I know you've mentioned about your condition, and we don't know exactly the actual specifics of your condition. But one of the things that really made a lot of us feel quite confident when the vaccines were being rolled out right at the beginning of the vaccination program was that for a lot of previous clinical trials, one of the concerns really is that a lot of Black, and I mean Black African, Black Caribbean, Black American communities had normally been either excluded or had very little input into those trials, or on the flip side is where they had been involved against their will. They hadn't been given information, and therefore they had not been given the same level of knowledge or that other people, the white Caucasian communities had access to. And that is historical, but that is the fact. Now, in this particular vaccination schedule, when we looked at the data, one of the things that gave a lot of us of African and Black heritage a lot of confidence was that this was trialed in so many countries along the across the world, and it did, by its very nature, what the investigators did do was that they actually went out and took a broad cross-section of individuals, including a lot of Blacks and Black Africans and then other sort of quote unquote minority communities. And so the data that was came out as a result of it actually included us with our skin color, with our skin tone, with our heritage in the information that was in the trial data. And so the trial data that we know that was, and the efficacy of it was also meant that it included us in those numbers. And so we were represented in those trial data. So there were trials, some were trialed in 6 countries, in 8 countries, and the trials are still going on, but it does have a broad cross-section of ethnicities. And I think for me, that is a real, that has given me a lot of confidence. I must say I have had my vaccine, I've had the 2 doses, and the trial data that is coming out, plus the current data as it continues to come out, has shown that on the whole, it is safe. And so for us, that's really a real form of confidence to come forward for it. But that was one of the reasons that a lot of us were worried. But when we looked at the data and we knew that, yes, a lot of Blacks, a lot of Africans, a lot of ethnic minorities, quote unquote, were all involved in those data, that gave us a lot of confidence.
Thank you very much, Pearl. If I may add to that, Marilyn, and first of all, I'm sorry that an NHS blunder has caused you to have ongoing condition, which is still affecting you till today. I'm really sorry to hear that. But just like my colleague has said, and I think one of the things we need to appreciate here is the fact that we do not have longitudinal views of this vaccine. And we all know that because we've only had COVID for the past just over a year, and the vaccine has been out for less than that. I think the government has been open and honest in saying we do not have this data available yet, rather than trying to pull the wool over your eyes and saying, oh, it doesn't do this, it doesn't do that, it doesn't do that. But what they've said is we are awaiting this data so that when it comes out, it is correct and it is factual, rather than giving you something that is not right at the moment. So I can understand your reticence based on your history with the NHS and saying, I really don't want this. But just like Pearl has said, we've had a lot of people included in the trials. I've had both my vaccine as well. And we know that more people have had benefit from it than those that have had disadvantage. We're not here to try and convince you to have it, but to answer your questions in a factual manner so that you can make an informed decision. Thank you.
Thank you. Marilyn, you okay with that?
Yeah, I'm good. I'm just waiting for the data too. So I think my conclusion is I'm going to wait for more data just to see how the medications and stuff interact with each other. But thank you so much for taking the time, and I really appreciate you coming today and sharing information, because that's definitely what's needed in the community. So I thank you.
Thank you very much, Marilyn. I can see that we've got 17 or more questions in the chat box. However, there may also be, if like Marilyn, you feel desperate that you don't actually want to ask a question, then please put your hand up. So the next question that in line with just going through one at a time, can the doctors talk about blood clot issue with AstraZeneca vaccine? Is this going to slow down the uptake? I think is a question.
Can I take that?
Yeah.
Okay. Yeah, so we have data that's coming out, obviously confirming that there are incidences of blood clot with the AstraZeneca vaccine. That has affected the uptake of the vaccine in Europe. And I'm having, as a GP, I'm having more and more of my patients ring me, asking me if it's safe to take this vaccine. And the simple answer remains that we view everything from a risk-benefit ratio basis. And yes, there is an association. That's what we have to call it at this point in time, because we can't say it causes blood clot. We can say there's an association that has been found, and that's been investigated both by the MHRA and EMA. Lots of the bodies, medical bodies, regulatory bodies are investigating that. So for now, we say there's an association. It's more number of people have been found. I think as at the data from the end of March, I think about 79 cases have been found. In considering the number of doses of the vaccine that has been given in the UK, about 20 million, I think, has been given. So when you compare that, 79 cases of blood clots, out of which there have been about 19 fatalities, to the number of vaccines that have been given, it's still a relatively very, very small risk. I think the government has also come out as of the publication, the most recent publication, to say that people who have had blood clots in the past, or people who have had particular components of the blood called low platelets, even in those people, there's still an opportunity for them to have the vaccine. Again, this has got to be looked at on a risk-benefit ratio. But if you're less than the age of 30, then they're suggesting that we offer those people a different type of vaccine as opposed to the. So in Europe, there is definitely a slowdown in the uptake of clinical vaccine because of association that has been discovered, but we haven't necessarily found that in the UK as of now. Hopefully, the investigations that are ongoing will continue to show that this is still a very safe vaccine to use, and that the risk of blood clots is very low. And in addition to that, what we're saying to people, I did speak to a patient over the weekend that presented with
I think we've lost Obi there.
7-day history of progressive health. There's evidence now to show that anyone who's presenting with headache for more than 4 days should ideally be speaking to their GP, and we should be taking that quite seriously, especially if it's a progressive headache. And in addition, if the patients have other symptoms like painful swollen legs, or they're feeling breathless, having chest pain, then they also need to be speaking to their GP.
Okay. All right, Clive, can I just add to what Obi has said as well? And I think it's all trying to put things into perspective. Obi, thank you very much for that answer. Just like Obi said, in 20 million vaccines that we've given, we've had a case of about 79 blood clot association. We're not sure if it's a causal factor as it is at the moment. Now, if you juxtapose that against the risk of having thromboembolism in people who have oral contraceptives, it's about 2 to 6 per 10,000 people who have oral contraceptives are at risk of having a blood clot. That is a higher risk of getting a blood clot from an oral contraceptive than from having the AstraZeneca vaccine. So it's not saying people shouldn't talk about it, people shouldn't be concerned about it, but what we're trying to say here, it is an association, it's still being investigated, but it is very, very, very low. So if you had to put it in percentage, you'll go 0.0000000, you go 4 zeros before you get 395. That's how low it is. It is present, but it is very, very low.
I suppose the answer to that question is that one is open that for the well-being of the community, that it doesn't slow down the take-up of the vaccine, because clearly the benefits are significantly more than the risk that might be involved. Okay, so next question is, and this may be one for Lynn, to be honest, why is the CCG so keen for the BAME community to have the vaccine, given they've never cared about the health inequalities in our BAME community in the past? So that's the question, and I think probably that's a question for the CCG rather than you doctors. So Lynn, have you got a view on that question?
It's a good question, actually, Clive, and I think Jim will support me. We are concerned about our BAME community. This has really highlighted the plight. You know, nobody anticipated the death rate and how the community would be impacted. So for us, it's really important to address those inequalities and make sure that we are reaching out, we are communicating, we are addressing what's causing hesitancy to try and see if we can turn that into some confidence in having the vaccine. But it is a key priority that we protect our BAME community. And we're also recognising a lot of our health and social care workers are BAME as well. So it's a real community spirited approach. And I think what we're doing this time, I have to be honest, the work we're doing with Hertfordshire County Council and our district teams in Watford Borough Council, etc., has been really a catalyst for change, I would say. So we've seen some great work. They've got the contacts, and I think we will just start to build on this from this point onwards.
Thank you very much. I should say from the Watford African Caribbean Association's perspective that we certainly welcome the opportunity to work closely with the health sector, because there's nothing we're more concerned about than the well-being and the health and well-being of our community. And I think it's a good point that actually we do know from a whole lot of data that our well-being, health or otherwise, has not necessarily been the forefront of the thoughts of our authorities that we're relating to. Let's hope the one positive that might come out of COVID is that this does change and change for the better once and for all. Thanks.
Sorry, can I? Yeah, is it all right if I
yes,
say something
yes,
in addition to this? Yeah. So thank you so much. And I think you know, as a health professional, and that question is very relevant and it's very topical. And you know, it is something that does cause a lot of angst and anguish amongst both clinicians and patients, especially if you're you know, if you're Black, Afro or Caribbean, or you're non-white. What I do want to say in response to that is, unfortunately, this disease, this condition has really, apart from highlighting the inequalities that we knew were there all the time, but were never in the forefront of the authorities' minds, what it is unfortunately, it's a very personal thing, in the sense that most of us know somebody or have family members who have been ill or died from COVID. And what we're trying to do is to pull back from that precipice. We're trying to, you know, reduce our risk. Most of us work in public-facing jobs. You know, there are lots of multifactorial reasons why we have been adversely affected, but for the mere fact that we work in, a lot of us work in public-facing jobs, so whether we're healthcare professionals, we're in social care, where we work in shops, you know, our husbands and our brothers and our dads are security officers. You know, we have a lot of public-facing jobs. We are bus drivers, you know, so we are in the public space most of our working life. We don't have the opportunity to sit behind a computer and work and make an income for the most of us. And so it's more important for our group that we do come forward and find ways to protect ourselves. For a lot of us, the furlough scheme was not appropriate. It didn't affect, you know, because if you have to go out and do that job, or you work as a first responder, or you work, you know, in an essential capacity, you still had to go to work. And so finding ways to protect ourselves from this disease is key for all of us. And what we are really working hard to do is to make sure that the disease does not take a foothold in our communities, and then we become left behind because you know, because of fear and of worry. So I think we really need to think about how we can protect ourselves in the present moment and in the jobs we do, and so that we do not become, you know, communities of, you know, of COVID, you know, COVID infection, yes, COVID hotspots. That's really what that's what we need to do, because we don't want to lose any more people. We don't want to lose our elderly parents or our husbands or our sons or our mothers or our fathers. So I think it's really important that, despite the difficulties we've had in accessing healthcare in the past and the inequalities within the health system, we take up maximum opportunity that this is giving us to protect ourselves so that we can continue to provide for ourselves and our families. And that's really what I would say. So thank you for that. And I think that that's a really important question.
Thanks very much. I think, Jim, you wanted to come in before I move on with other questions.
Yes, it's just to agree with what Lynn and Dr. Pearl have said very eloquently, that the County Council Public Health Panel recently had a report on health inequalities and the impact of COVID on BAME residents, and I've pasted the link in the chat and people can read it. And it is, in short, the reason why we want people to take up the vaccine is because I don't want to see a single other Black resident die. And nor does Lynn and nor does Pearl, and Pearl was incredibly eloquent. There's another reason on top of that, which is if we get a third wave, our Black residents will, as in the first and second waves, be in the forefront of it because of the jobs they do and the exposures they have. And Pearl has highlighted that strongly. And I think the third reason is if enough of us have the vaccine, we will protect those in our communities that can't have the vaccine. It's called herd immunity. And there is some good science behind proper herd immunity, not some of the nonsense that's taught. So I get my vaccine not just for me, but to protect other people who can't have the vaccine. And if enough of us get it, there are, and proportionately there are more Black people who can't have the vaccine for medical reasons than there are in some other populations. So actually it's really important as a sign of love and solidarity to our neighbours to get the vaccine to protect them as well as ourselves.
Thank you, Jim. Okay, moving on with questions. How is it decided when those with asthma will be vaccinated? Don't know who can answer that. Anyone?
So what was the question about asthma?
How is it decided when those with asthma, or asthmatic people, will be vaccinated? I suppose it's within the priority scheme of things.
Yeah, so I mean, essentially the JCVI, which is the Joint Committee on Vaccination, sat down and looked at, the general population and basically started to group people into different categories. And based on that, the vaccination has been in line with what the JCVI has actually rolled out. And we started with obviously the most vulnerable people, both in terms of age or in terms of associated medical conditions. But working our way down to the least vulnerable people, the younger population who are healthy. And that's what we've done. And we're unique in that not a lot of countries have the equivalent of the JCVI and have a structured vaccination program like we have here. And that's what we're following, really. And so the asthmatics, obviously, and those that have respiratory conditions like COPD, were amongst the top priority of people, apart from the people who are elderly and residential homes.
So does that mean, because as somebody who's asthmatic myself, yes, I've had my vaccination, but it's probably due to my employment than anything else. So if you're just an asthmatic, you're not in the priority group. I presume that's where the question is coming from. Is that what? So it's either you'd have to be in it for other reasons rather than because you're asthmatic. Is that the case?
So just being asthmatic, there are lots of people who are asthmatic in our books, like the surgery, and they hardly have any asthma attacks. The asthma is well controlled. They hardly use their inhalers, or their asthma is very stable on their inhalers. So they've never needed to have hospitalization. They've never had severe asthma attacks. those people would not be in the priority group. The priority group would be for people that fall into the more severe category of having asthma or any of the other breathing problems.
Yeah, okay, thanks very much. Thanks very much. So the next question, what age group will be vaccinated at the weekend? Just to say before you answer that is that we have got a scheduled vaccination center at the Holywell on Sunday between 10 and 10 a.m. and 1 p.m. So I think the question is about with the age group for that session. I think it's 50 plus if I remember correctly, but Lynn, I see you nodding, so I don't know if you want to say anything more to that.
Yes, at the current time, GPs, our GP practices that are delivering the vaccine programme are commissioned to vaccinate patients aged 50 years and over, and those, as Obi says, clinically extremely vulnerable, household members of patients that are immunosuppressed, and carers and all our health and social care workers. We are waiting for NHS England's agreement that we can move down into the under 50s and the under 30s. And that's expected probably within the next week.
Okay, so probably not in time for Sunday, but okay. So next question, how is having the vaccine curtailing the virus or suppressing the transmission of the virus when it has been stated that—
Clive, Jim's got his hand up.
Yeah, no, it was historically. Stated that having the vaccine does not prevent us from getting the virus or from passing it on. So I think it's about, sorry, who wants to answer that?
Right, so I can take part of that, and I'd be happy for my colleagues to come in. Now, vaccination and vaccination programs have worked around the world for many years for lots of different conditions. And if you're Black and African, I'm Nigerian, I'm of Nigerian heritage, we know that, for example, in areas where there's a good uptake of things like polio and measles and diphtheria and all of those, that we have much lower incidence of diseases in those communities. And the COVID vaccine we are so lucky that it's been proving to be as effective in that way. So vaccine and the vaccination schedules it's not new. I mean, all of us pretty much growing up have always had our babies vaccinated, and that's why we don't see those huge numbers of polio and diphtheria and all of those historical conditions that used to be those days. Now, in this particular condition, because the SARS-CoV, which is COVID-19, is a new virus, the vaccination itself, what we're doing is as the vaccination program is rolling forward, we're also then gathering the data in terms of the level of immunity that is given, the level of protection against health, and the levels of transmission. And what the data that is coming out is showing is that the more people who have the vaccine, that there is a reduction in, so we know that it reduces hospitalization, it reduces your risk of death if you are hospitalized, it reduces the duration of illness, and it's also showing now that it is beginning to reduce transmission amongst communities. So that is the information that is coming through from the data that is an ongoing, we are in a dynamic situation, but that's the information that we're showing. And so, we do know now that, people are less likely to get ill. If they do get ill, they're less likely to be hospitalized. If they're hospitalized, they're less likely to die. And then we also know that you're also less likely to pass it on. So because your body has already, once you have the vaccine, your body, I always think of, your immune system like your little army, gets an army of white cells ready to fight the virus when it comes. And so your body is already primed so that once you are exposed, your body can respond without making you ill. And we're seeing that is reducing not just your illness, but also your risk of transmission. So I don't know whether anybody else wants to sort of add on to that.
Okay, so there is an associated question, I suppose, that somebody has shared with me, which probably links to Jim, and it says, 41% of our community is optimistic, judging by the stats, Jim, that you've shared. what is the level of coverage statistically that we would consider to be acceptable, recognizing that 100% is probably not going to be realistic?
Do you mean the level of vaccination?
Yes.
I'd like to get us to 75% across every community, and I think we can do that because that's a good threshold, estimated threshold for herd immunity. I mean, we're already in the high 80s with healthcare staff. We're already in the high 80s with social care staff. Hertfordshire has a higher uptake of vaccination traditionally than most other areas. So before COVID came along, our uptake of childhood vaccines was much higher, including in BAME populations, than the English rate. So there is every reason we can do this. So that would be my desire to get there. And I think it will be those populations that are least well vaccinated who have the highest burden if we have a third wave of COVID. And it's quite interesting looking at our Gypsy, Romani traveller and Irish traveller populations in Hertfordshire, who are traditionally understandably reluctant about vaccines because they don't register with GPs. Their take-up of the vaccine has been very high and increasing. So I think there are causes to be hopeful here. And bear in mind, most people in the UK, or the polls suggest that, you know, easily 79% of people in the UK across all ethnicities, when the polls are analysed carefully, suggest that they will take the vaccine.
Okay, thank you very much, Jim. Colleagues, I'm conscious that it looks like I've still got about 30 questions that people have put in the chat, and we're 10 to. Now, are you available to, I'd certainly like to answer people's questions when people take the time to ask them. Are you all okay to almost certainly carry on beyond 7 in order to try and answer some of these questions? Okay, so the next question is, women in Australia are a lot more reluctant to take up COVID vaccine. Only 30% said they were confident in federal government due to the government handle of sexual harassment and the political culture. Are there similar issues here in the UK? It's a political question, I suppose. Anyone wants to tackle that? Jim.
I mean, I think the issue is vaccine hesitancy is different in different countries and vaccine intentions. So if you look at France, the international polling says actually that French people are among those least likely to want to take up the vaccine, but that's their intention. And that's because the French have a traditional mistrust of vaccines because of the French attitudes to government, and there's also issues about what happened with Louis Pasteur and vaccination starting there and lots of misinformation. But the French uptake of the vaccine has actually is way higher than the polls would suggest, even though their supply isn't good. If you look at Australia, it's actually in the UK younger men who are less likely from most research to want to take up these vaccines, not so much younger women. So there's a difference between us and Australia. But actually, the vaccine, when it started to be rolled out to people who are under 30 in Hertfordshire, mostly because of clinical conditions, very few people have turned it down. I mean, you're talking, you know, less than 10% of people offered it are refusing to take it in Hertfordshire. And that's young people who don't want it because they think they're invincible from COVID. So we shouldn't compare other countries in terms of hesitancy or questions with our country, because the UK has traditionally been a country that takes vaccines up quite highly, with the exception of flu vaccine, and that's just because we're far too complacent about flu.
Okay, thanks very much, Jim. Moving on quickly then, how important is it to have your second jab within 12 weeks? Obi, what do you say?
I would say very important. It's absolutely important to replicate what was done in the trials to get the results that we are getting in terms of the immunity that you're going to get from taking the vaccine. So it's absolutely important. You know, as of now, there's no evidence that mixing the vaccines is whatever vaccine they had first, they should still have the second doses of the same vaccine, please. Because again, a lot of my patients have asked me, is it okay to have a different vaccine from one? Yes, no, please.
Thanks very much. Just to, I've had an observation here that Dr. Pearl, that your suggestion about previous reluctance, the way previous vaccinations have been conducted would illustrate the fact that there's been this kind of ignoring of our community, in that we've not been involved in previous trials. And let's hope that won't be the case going forward. I think that's probably an observation more than anything else. So next question, with all the recent alarm on AstraZeneca vaccine on the issue of blood clot, what is one to believe?
Can I take that?
Yeah.
What one needs to believe is, one, we're in a pandemic. Two, COVID-19 kills. Three, the vaccine is safe and efficacious in most people that have the vaccine. I think those are the salient facts rather than going into waffles. So it is safe, it is efficient, and it is proven to be safe and efficient. That's what we should believe.
Yes, indeed.
Yeah.
Okay.
Sorry, can I just add on to that? Also, what I think people fail to appreciate is that the number of vaccinations, the number of clots, people who there is an inherent number of people who will develop clots in the community, irrespective of the vaccination. So that there is what we call an incidence. There's an incidence and a prevalence of clots in the community anyway. So, like we've said so far that you know, we don't know whether there is a direct link. There's an association. We're not absolutely sure, but the figures show that 1 in 1,000 people will get a form of clot if you're over the age of 45 and above. So the numbers are quite high anyway. You know, so to link it to the vaccination, I think some of the figures are coming out to actually show that that it may actually have protective information, but we're not absolutely sure. But so what I'm saying is that clots happen within the community in different age groups and for different reasons. So we need not to confuse that with the vaccine, even though the information is still being looked at. Thank you.
Okay, thanks. Thank you very much. A comment here is, which I can concur with, which says, I've had my first dose of the vaccine and I will be having the second dose very soon. I've not had any issue, by God's grace. And that's my position too. I've had 2 doses and no problems whatsoever. And I did have the AstraZeneca vaccine, but of course I'm not 30 or below, believe it or not. Anyway, next, some useful information has been provided by Zoe here. So next question, I agree with Lynn and, sorry, that's Jim making an observation there. Okay, so question, whilst we want everyone to take COVID-19, there are certain groups of people who can't have COVID vaccine. Can medics please elaborate on this, e.g. people with allergies, children under 16, pregnant women? Dr. Pearl, were you?
Hello, yes, I can take that and I'm happy for my colleagues to step in. So we know that the COVID has affected a number of people or different groups of people disproportionately. And so for those particular people, those are where the vaccines have been targeted. we do not have the figures, or the figures are not available for those groups for which the JVCI, that's the Joint Commission on Vaccinations, have said not to take it for now. So, the essence was that the safety information, the data isn't there, it hasn't come out, and for all sorts of ethical reasons, vaccines have not always been tried on different groups of people. So, for example, pregnant women. But we do know that if you're pregnant, but you do have an underlying health condition, so far it has been proven to be safe. So if you're pregnant, but you're within those groups of people who, underlying health conditions that put your risk of hospitalization or death much higher should you get COVID, then you will be. That is a discussion that you will have with your GP or your clinician to see where your risk balance lies. And so we are not saying it's not safe. We're just saying that the data is not available. Now, when it comes to things like allergies, I work in a general practice. I'm a general practitioner. I work in a surgery. We have been running vaccination clinics since December, and we have had very few reasons to turn people back because of allergies. So the only reasons why we have actually turned people back from with allergies is if you have quite severe allergies, or you have allergies to any of the known components of the vaccination, or if you carry an EpiPen. So those are the only reasons. So if you have a bit of hay fever or a bit of a snuffle or that sort of thing, so far it's been proven to be safe in those groups. But if you have what we call severe allergy, whereby you have to carry an EpiPen, then we would say probably at this stage the vaccine is not for you, just because we don't have that safety data. In terms of children and young children, we don't have data as well so far, but I believe that information will come through. So it's really because we don't have the data available to say these are the groups that it's been trialed on. And for children, we know that irrespective of of the COVID-19, they may get the infection, but they are not as badly affected as the older groups. So they don't have the same level of illness, they don't have such bad outcomes in terms of hospitalization and death, and therefore they are less affected than some of the higher groups that are the priority groups for vaccination. But we, as the information continues to roll out, it is a changing picture, and then we will know what the JVCI advice is going forward. As a GP, I was really worried over the last winter, because normally we have the winter colds, and we have so many children come in with the winter cold and the winter virus and the bronchiolitis, and we were really, really lucky that with all of the measures that have been in place, including in terms of washing hands, wearing your face mask, that we didn't have that surge of the winter cold virus that we were expecting. And so we will have to see. We know that children are relatively robust in their in their immune systems, and we will see what the JVCI will advise us going forward over the next months and years.
Clive, can I just add to that?
Yes.
So I think Pearl has touched on people that can't have it because of allergies, and she's absolutely right with that. The under 16s, the trials did not include people in that age, so we technically can't talk about the vaccine being used in that age group, or it's going to be effective in that age group. The third group is what is the interesting group. I think people who are pregnant, and to expand that even further, we need to look at three categories. I think we need to look at women of childbearing age, we need to look at women who are pregnant, and then we need to look at women who are breastfeeding. Okay. Now, women of childbearing age, there's absolutely no evidence that this vaccine will affect fertility. So people can absolutely go and have it, and it will not stop them getting pregnant. So I think we just need to put that out there as well. People who are pregnant, again, the evidence is, I've had 3 of my patients who are pregnant, but because of the kind of work they do, 3 of them worked in care homes. And as you know, the nature of the work and what they do and the kind of people they come in contact with, they are high risk of getting it. So 2 categories of people who are either high risk of getting the virus because of the kind of work they do, or people that have medical conditions put them at high risk of having a severe illness or dying from COVID. And those are the two people if you're pregnant that we're saying can have it. Okay, so it's not an absolute. The ingredients that are contained in the vaccine are not known to be harmful. However, pregnant women haven't been included in the trial. So we're just saying, on the whole, not all pregnant women should have it. But if you fall into those two categories, then really you need to start having it. And 3 of my patients who are pregnant have had it. Have had the vaccine, that they've been absolutely fine. One of them just had a baby, I think 3 weeks ago, and she's fine. The third category is women who are breastfeeding. And again, there's no evidence that the ingredients of the vaccine will affect the babies. So breastfeeding mothers can actually have the vaccine. Okay.
Thanks. Lynn, did you want to say something?
Yes.
You're muted.
Sorry, can I just add to Obi and Pearl, just to let colleagues on the call tonight know that if they've had a previous history of allergies or they've had a reaction to their first vaccine, we have put in place a pathway where GPs can refer to the local hospital, to Watford General, so that they can be seen by the consultant there that deals with allergies, immunology, and then they can then review the patient and determine if they have the vaccine. And if they do, they can offer it in a safe environment like the hospital, where they've got more facilities should someone become unwell.
Thank you very much for that. Next question is, there is already talk about a possible need to take 3rd dose of the vaccine in the autumn. Can Jim or doctor give more information, if any? Third dose of the vaccine in the autumn.
I think at the minute we don't know is the honest answer, and if we do need so this would be a booster dose if we had a variant that escaped the vaccine. And at the minute, the vaccine works against all of the variants that are in the UK reasonably well. And bear in mind, this vaccine is better than flu vaccine in terms of efficacy. So we have 2 issues to sort out. One is we need to keep the number of variants as low as possible. And actually, every time somebody gets COVID, the virus gets a lottery ticket to develop a new variant that might escape the vaccine. So far, we're okay. If we get variants that really do evade the vaccine, then we may need a booster. And in fact, the British Society for Immunology produced a really good paper on that last week. So for the minute, we may not need one, but obviously the research is underway. I sit on the National Vaccine Board, the National Vaccine Equality Board. The research is underway so that if we do need a new vaccine, we've got them by autumn. Does that, I don't know if any clinical colleagues want to either add to that or indeed clarify anything I've just said.
No, it seems not. Okay, so moving on. Should women who are pregnant or who want to, okay, I think we've had that question answered. But just to say, somebody's made a point that Dr. Pearl, thank you for those key points. Communities are key to this and working together and working in partnership, which something I would concur with. It's about us working together across the piece. Okay, sorry. Let's see, next question. A COVID-19 vaccine clinic, all well. Okay, so that's when the clinic is taking place. That's on Sunday, and I think the details of that is in there. And some more information about whether if you're clinical or vulnerable. Okay. Okay, so next question. Are Black people more prone to the virus because of their genetic makeup, or is it a societal problem? If it's due to our genetics, why are the numbers per capita so low in the Caribbean and in the African continent?
So I will come in there, and I'm sure my colleagues will also have a view on this. So unfortunately, the African and the non-white, the ethnic minorities have borne the burden of COVID-19 in the first wave and in the second wave. Now, it's multifactorial. That means there are lots of reasons why this has happened. We've talked about the jobs we do. So a lot of us are in forward-facing jobs. We are in, we are public-facing jobs. So that we are the bus drivers. We work in the shops. We're in the care homes. We do a lot of the low-paid jobs in the community, and that's a fact. And second thing is that a lot of us did not have the opportunity to be furloughed. And so people were still having to go to work. Sometimes we live in larger houses where there are multi-generational people or large homes. So you might live with your elderly parents and your sister and your brother, and you have a large number of people in one particular household. So these are some of the facts that that have made us have an increased burden. Another thing is, I think partly is our health-seeking behavior. We do know that Africans and Afro-Caribbeans and even non-white populations are less likely to come forward early when they are unwell, and that's really because a lot of them either do not know, if you come from you sort of come from the culture you're from. And so whereby a lot of people would stay at home and think, well, I'll just take a little bit of honey and ginger or whatever and stay home and manage yourself at home. Sometimes what it does mean then is that when people do present to the hospital, they're much sicker because they stayed at home much longer. So they become much iller by staying at home. And of course, a lot of people were worried about the myths that were going around that if you go into hospital, you won't come out. And so therefore, people were really staying at home and becoming really quite ill. Now there are lots of multifactorial aspects of COVID that have affected the Black community. There are some other sort of intrinsic facts. I think people have also had concerns about the level of care that they experience when they get into hospital, and that has made people reluctant, or when they do present, whether their symptoms are given the same weight of the same value as as their white counterparts. And another thing I think is also the language, the language of communication. So both the visible and the non-visible cues. What do you say? What do you mean? How do you say it? And how that is taken up and interpreted by your clinician. So there are lots of many things. There are lots of reasons whereby we have had an increased burden of COVID. There's a talk about why is it not so bad in some of the African communities. I mean, people like me, I'm of Nigerian heritage, and we were really we were really worried and frightened about what would happen if it came into the African continent. But as it is, and by God's grace, the burden hasn't been the way we had worried or we had feared it was, and we're so thankful for that. And part of the reason is we feel is because we have a much younger population. So the average population, we have the bulk of our communities back home are much younger, and therefore they are much fitter, and therefore they are much less likely to become ill with the disease, and therefore they're less likely to die. And so there are lots of things. Another thing is so these are several aspects in that have given us an increased burden, and this is why we're actually, because the vaccine has been proven to be safe and has been proven to be effective, what we are then saying to people is, we know that we have been disproportionately affected by COVID-19 in the UK. So now we have an opportunity to look after ourselves, to protect ourselves, to protect our older parents who we look after, and and to be able to be the support system for our younger communities. Our children who depend on us. And of course, a lot of us know that we have networks back home that we also support. So we need to be able to stay well for all of them. And so that's why we're talking about, if we become ill, it's not just you that's affected, it's the whole network that depends on you. And so that's why we're having these vaccination questions to say, look, we know so far on the whole that the vaccine is safe. it will give you the, it's efficacious. So it will give you the protection that you need to the best of what it's able to do, and it will mean that we are able to work in the communities and in the jobs that we do going forward. So I don't know whether my colleague would have anything else to say about that.
Okay.
I think, Pearl, you've said almost everything quite clearly. Just like you said, number one is the jobs we do. Two is the fact that we're worried about how our health-seeking behaviors and all that. And if you look at the African setting as well, at times there's also some paucity of data coming out from there. Though we do agree that there's a lot of we have a lot of young, very active people. At times I say a lot of the people who have all the other health conditions over there probably have also gone. But you've said almost everything. So there's not a lot more for me to add here.
Okay. Thank you very much indeed. Next question. Are Black people more prone to the virus because of the, okay, sorry, not a question. Okay, so I'm due to take my second AstraZeneca vaccine. I experienced severe side effects with first dose, right side paralysis for 2 weeks, vomiting, persistent headache, severe swelling, cellulitis, and shortness of breath. I suffer from asthma. Would the panel still recommend I get the second dose?
Yes, I would say the answer to that for me would be yes. I think that the reactions are not in the class of reactions, say, as severe anaphylactic reactions. It's difficult, obviously, to know to what extent all of those symptoms, when and how those symptoms evolve following the vaccine. So I would certainly advise that you speak to your GP and have sort of a one-to-one discussion, and that's what we're there for. We're having this sort of daily basis with people that have had either reactions like this to the first dose, or are worried about taking the vaccine or because of underlying health conditions. So I would certainly advise, just on a blanket basis of what has been put, the answer for me would be yes, but the best approach would be please speak to your GP, have a one-to-one consultation. I'm assuming that some of those things will have been noted by the GP when it happened. So, they might have been already.
Just in support of Obi, if your GP said, okay, I'm slightly concerned, there is that ability to refer the lady to the consultant at the acute trust at Watford General.
Okay, thanks very much. Another question. I understand what is happening in the UK in our community and why. What I don't understand is why the numbers are so low in the Caribbean or in Africa. And I don't feel that my questions have been answered. I suppose that the position is that, for example, I'm from Jamaica, and when I looked at the figures, Jamaica's got about 600 deaths, just over 600 deaths. The compared population to the UK means that they should have about 15,000 deaths on my estimation, and they don't. So I suppose the point, is there any rationale as to why? I should also say, though, that recently Jamaica has been going through a significant second wave where numbers have been going up quite a lot, and much more so than over here. But in terms of the question that's been asked, is anyone able to offer some reasoning as to why that difference exists? Because clearly the difference exists statistically.
So I'll just drop a little nugget here. So and this is anecdotal, so I don't have the full figures because the figures aren't out there. But I mean, if you're African or you're Caribbean, you come from a village, and a village is a small hamlet, that sort of thing. It's not you're not coming from the town. We're not talking about town numbers. In some way, they are relatively isolated. So people interact, but the movement of people is not so much. So a colleague of mine went to one of the villages and did a random swab, and of that swab, they did, I think they did about 100 that were swabbed, and about 70 or 80% were COVID positive, but they were not ill. So what it shows is that, what I think it is showing is that it's not as if to say the disease is not in the community, it's just that people are not getting ill with it, or they are not getting severely ill. And I think that's a blessing. Now, we're not absolutely sure of why that is. Like I said, whether it's the high levels of vitamin D, whether it's the inherent immunities within the communities, whether it's the fact that these are much younger age groups that are being affected. Because, and so those are some of the theories that are being postulated. But, I think for long blessing, that we can only just count it as a blessing. So I don't know if somebody else wants to, to contribute.
The other thing that I've come across is the fact that the age profile of the population is very different in Africa and the Caribbean, much younger. And of course, we understand that this condition impacts on older people more. So consequently, with younger population might be less. Did anyone else want to say anything about that?
And I think that's also a challenge for us as Africans and people from the Caribbean to go back and have a look and see if we can come up with some scientific evidence as to why this is happening. Yes, we have herd immunity. We have a younger generation, younger population who are, from what Pella said, who probably are positive for the virus but are not being ill with it. So let's go back and do something. Let's go and research it. That's why we're scientists. So that's what we should be doing. So that question to me is a challenge to us as people from this background, from this origin, to go back and see why this is the case.
Yeah.
Okay, in other words, watch this space. We're going to try and find out what the answer is.
Yeah.
Okay, so next question. And I don't know who's going to answer this. Jim, you might have deep pockets, but what support is there for breadwinners if they can't afford to be sick?
Well, there's several sets of support. The first is that there's an organisation called Herts Help, which is a coalition of community organisations, and they can do several things. So there is a self-isolation payment, which you can have if you need to self-isolate. And we've actually put an extra 3 million into that in Hertfordshire for discretionary payments, and they're administered by the district and borough councils on benefits teams on behalf of the Health Protection Board. There's also help available with shopping and help available with collecting and delivering medicines. We can get you, oh, brilliant, Justine's there, oh, brilliant. So you can see that Justine, who is nothing if not quick off the mark, has already put in the link in chat. There's a range of other support. So if I can do a wee bit of a plug for a whole load of agencies in Watford, including the council, in terms of organising transport to vaccination for people, they've been brilliant at that. There's also the ability to refer people into money advice. If you are ill with COVID, you are entitled to sick pay, obviously. So Herts Help have helped something like 2,000 people claim benefits through COVID, and they're there for you.
Okay, thank you very much. Recognize what the time is. I think I've got about 3 more questions I see in here. So I'm going to suggest that we don't have any more questions unless anyone has a really burning question that they want to put in now. And we'll just try and answer the questions that are there now. So the next question is, somebody said, thank you for your contributions. This will help many people to make an informed decision in having the vaccination. But the question is, what are the long-term effects of these vaccinations?
The vaccine is new, so we do not have longitudinal views of it. So you can only tell what the long-term side effects are if you've had longitudinal views of it. Now, what we know is there are vaccines of similar makes that people are already having. And we are comparing this data with that, which is showing that there are not any long-term side effects. But this is a separate vaccine. We have to own up to that it's a separate vaccine. We do not have longitudinal views of it. From those who have been involved in the trials, they have not come out with any long-term side effects thus far for the period which they've been under review. So that's a good evidence to show that it possibly doesn't have any long-term side effects. But we only know as far as the vaccine has been rolled out, or from the trials that we've done for the vaccine. We can't say into the future. We can only compare with vaccines of similar makes that have been out, which is not showing any long-term side effects.
Okay, so I've got a question here which is prompted, I think, by the information that we've now got about AstraZeneca. But the question is, what if you decide not to have your second dose? I suppose the question is, what is the implications of doing that, of not having your second dose?
The implication remains that you may not get the maximum benefit that the vaccine offers. So you may not get the maximum protection because the studies were done on you getting the full benefits from having 2 doses. So if you have 1 dose, means you may not have the full benefit.
Okay, thank you very much. And this question is, what is your opinion of vitamin D in the prevention of getting COVID, in preventing getting COVID? Vitamin D is important.
So there has been a few, 1 or 2 studies and things, that publications regarding vitamin D and COVID. What we do know is that there's no clear evidence that taking vitamin D will prevent you from having the infection or the severity of the infection or hospitalization. So when people ask me, I say to them, apart from the vaccine, which we know now is very effective in reducing that, or the measures of washing your hands and wearing face masks and also social distance, vitamin D, there's no evidence that vitamin D gives you any sort of protection. Lots of countries, like in some African countries, people are going around and buying lots of vitamin D tablets. And I mean, even here, a lot of people are doing that as well. It might improve the general immunity, but there's no specific protect you from infection or variety of infection.
Okay, thank you very much. There's a question about vitamin D again, but I think the question was really whether or not it is, could that be a factor in the low sort of incidence of COVID in Africa? But I think you probably have answered that. I think a final question I can see here. Does the risk of blood clots last as long as the efficacy of the vaccination or longer? So does the risk of blood clots last as long as the efficacy of the vaccination or longer?
It's difficult to understand what that question is, because I'm not sure. I mean, the risk, if you're going to have blood clots, then most people that are going to, the few people that are going to get it, the very few people that are going to get it will probably get it within, we're going to say the first 2 weeks of getting the vaccine. There's no evidence to show that 3 months down the line or 6 months in the vaccine, you're prone to getting blood. No, absolutely not. And the second part of that question is, do we know how long the vaccine is going to give you immunity? We don't at this point in time. It could be 9 months, could be 1 year. We're still not sure if we're going to get booster doses. But certainly, when you look at, said all night, if you look at, once you weigh the risk and benefits of having the vaccine or not. The benefits far outweigh the risk. The very small risk of blood clots and skin is not really a reason why people shouldn't consider having the vaccine unless there was something else underlying, in which case, if there are specific medical problems, then please speak to your GP about it, especially if people don't want to those very specific this forward.
Okay.
And if I may add to that,
Okay.
we are seeing, since we've rolled out the vaccination program, we're seeing death rates have gone down, hospitalizations have gone down, ITU admissions have gone down. The government is beginning to open up the country gradually, so which means the vaccine is working. A lot of people, some people, yes, have had blood clots. We don't know what the relationship is as yet as full. The question is, were these people on their way to getting a blood clot and they stopped by and had the vaccine on their way? Hence, we've got this causal relationship. We do not know. So the positive message we should be sending out to people is that the vaccine is safe, it's effective in curtailing this virus, and it's keeping people safe. And the soft data, as I mentioned earlier, based on studies that are coming from Israel and the care home, is that it's also suppressing the transmission of the virus by up to about 67%. And that is what we should be focusing on. There are a lot of good things coming out from having this vaccine. We've got a few negative aspects of it, which we acknowledge, but it does not outweigh or even come significantly close to the benefit of us having these vaccines.
Okay, I said that was the last question, but there's a thank you here, which is almost a question too, which is thank you for your response. I'm pleased to hear you confirm that a lot more research is required before we rush to take the vaccine. I'm not sure that's what you were suggesting.
So if I may take that, I read that particular comment, and what I would like to say is that vaccines on the whole are safe. They've been around for more than 50 years. Vaccinations are not new. They are safe, they are protective, they are one way in that reduces widespread communicable disease. So which is, things like colds and flus and diphtherias and polio, all of that sort of thing. We know that vaccines are safe. What we, this is new, and I think because it's new, it seems as if it's come from somewhere that's unimaginable, but it's not. These are the technologies that have been used over years to protect ourselves and protect our children. And so I remember when I was in medical school, with diphtheria, we didn't have children with polio. Measles is no longer a thing of the past. We hardly see mumps. So there are lots of better benefits to vaccinations. And what we have seen is that COVID kills. And it's not just that if you get COVID and you're going to be hospitalized. The worry also is that there are now long-term conditions called long COVID, whereby some people have COVID and they have months and months of ill health. So it's not just being sick and dying, but also the long-term effects of having a severe COVID illness. And so what we're trying to do is to give you the information that you need to make that informed decision, but on the basis of the fact that the vaccines are safe, they work because we can see from the evidence, they will keep you well. They'll not only just protect you, they'll protect your family members, they will protect other people in the community. They'll allow you to go out into the world and do the job that you do, whatever it is, whether you sit behind a desk or whether you get on the bus, whatever it is, you can go out with a level of confidence, knowing that your risk of getting ill or dying is so much less. So I would just encourage people to really think hard about, the fact that we know that we have been, people of my color, of your color, have been disproportionately affected by COVID. We don't want to see that anymore. That in itself is a tragedy, and we want to reverse that tragedy. We want to be able to, to come forward with boldness, take what we need to take to get ourselves back on our feet and to be protected and protect others. So that would be my message to you. Thank you.
And if I was going to add to that, over years, yes, we all grew up in Africa, Caribbean, or even in the UK. We all had vaccinations when we were younger. So just like Pearl said, vaccinations are not new. We've seen the eradication of smallpox. polio is on its way out. And these are all due to the vaccination programs, successful. And most of these vaccination programs did not include Black people in the trials, but they have been effective in Black people, in Black children. And then, so what we should be looking at is, just like Kupel has mentioned, is that we have been disproportionately affected by COVID. Now, we talked about the health inequalities that exist. Why are we again, as a Black community, dragging our feet? I understand that there's a lot of caution, but we also need to go back and also do some soul searching. And my friend in America says this to me. So when people come and ask him, should I have the vaccine? He goes like, if that white man who has $5 million in his account is climbing all over you to go get the vaccine, go get the vaccine, because he will also save you as it saves him. And we need to start looking at things positively. I know we've been disproportionately affected. I know we've been treated badly, but there's always a saying that says, the enemy of my enemy is my friend. And at the moment, COVID is our enemy. So we all need to work together to come and defeat this enemy. That is what we need, a collective effort.
Thank you very much. Actually, you've kind of started what I was going to ask you all to do, which is to share any final words. So maybe some of you have already done that, but let me go around. I'll start with Jim. I know you weren't formally on the agenda, but you've listened to what's been saying. Any final words from you?
I just want to thank you for your kindness tonight in including me on the questions. That was very kind of you. I'm struck by the kind of passion of Pearl and Charles and Obi, you know, and I know that Lynn and I share an absolute commitment to wanting to get people vaccinated. I don't want a single Black person to die in our county from COVID when they could be prevented by the vaccine, because they are precious. The diversity of our county is part of our success. Every life is precious. We must do everything we can to protect each other. So please, you know, take the vaccine.
Okay, so Lynn, any final thoughts?
I would just like to build on what Jim said. There's a real commitment. We don't want to see any family go through the pain of seeing a loved one, you know, admitted to hospital or losing a loved one. It's a real priority for us. And that's why it's important that we do obviously look at how do we deliver the vaccines in centres that are convenient, where people have got confidence, and actually take the time to listen to your concerns, answer them. And if we're not answering them right, which the lady on one of the questions says, you haven't answered my question, tell us, because we will do everything we can to answer your questions. We'll be as honest and as transparent as we can. And I'd just like to thank everybody for their time this evening. I appreciate, you know, that they've taken the time to join us.
Thank you. Okay, I'm going to go to the doctors now. Who wants to go first with the final words?
I'll go first. I think, thanks, Clive, for inviting me to this. I think the evidence is very clear, and I think that we know what the vaccine can do, and we know what the vaccine can do even more now than now that so many people have had the vaccine, and more data is coming up, you know, from the people that have actually had the vaccine. So in addition to what Charles said, we knew before the vaccine rollout that the vaccine was effective, and we knew it was effective in reducing severity of illness and also reducing hospitalization. But what is actually more important is that it actually reduces transmission as well. And Jim has also talked about herd immunity. So having the vaccine, you not just protect yourself, you also protect your neighbor, you protect your loved ones. So the evidence is really clear, and I'd like to, implore each one of you to please try and have the vaccine, because if we know it works, we know it's going to protect you. And if you have any specific question about it and you think we haven't covered it today, please speak to your GP. As a GP, I'm taking questions every single day from my patients about the vaccine. And you're welcome to, to ring anyone you know who's a clinician and also ask. I'm also taking questions from people that are my neighbors and my colleagues in other fields of my life. So please think about it. The choice is yours, it's not by force, but please make the choice wisely. Go out and take action.
Okay, thanks, Sobi. Pearl, Charles.
I'll speak and then I'll let Charles round up as our chairman. So thank you so much, everybody, and thank you for coming. Thank you for all the panelists. Thank you for everybody, to actually come and listen. And I'm passionate about people having the vaccine because when COVID started, as a GP, and I would go to work and I would hear of the number of people who are dying day in, day out. This is unprecedented numbers that we had never heard of. I look after a nursing home, and within a week, we had lost a quarter of the population. COVID is real. I've sat down on the end of the phone, supporting, women, whose partners are ill, saying, have you done this? Have you done that? Is he in hospital? It's heartbreaking, and it's real. So please, we are seeing that the numbers, the protection that you're going to get from the COVID will protect you from the worst bits of it. And we know it's not just the vaccine, it's not just the severe illness. There's a new syndrome called long COVID, where you can be ill for months on end, and most of us are breadwinners. We are the breadwinners for our families. We are the breadwinners for our elderly parents back home. We are the support system for our young children. We support communities. We don't just support families. We support communities, and so it's vital that we look after ourselves so that we can continue to do the work that we do and have other people, and support others. So please, I would really say, at this stage, there are in all honesty, I can't think of any reason why somebody would really be hesitant. But if you do have anyone, speak to the GP, speak to your colleague, get factual information. I always think of the information that comes on, via the social media. The people who put that information out take no responsibility for the effects. So, because they take no responsibility. If anything happens to you, you're not going to go to that post and say, but I listened to you. So this is you, this is your health, this is your family. Please do the right thing and, and really think about it, because it's you, it's you and it's your life and it's your family. And we've seen it, I've had people die from across even back in Nigeria, and they're still dying from COVID. So it is real. Let's do what we can to protect ourselves. Thank you.
Thank you, Pearl. Charles.
I think one thing we all need to understand is that we're in the middle of a global pandemic. This is one of the greatest health challenges that we all will see in our lifetime. And for us to be able to pull through from it, we need a collective effort. Now we have a vaccine, which is a game changer, which puts a positive spin on all the doom and gloom that we've been facing for the past 1 year. If you look at the global death rate from COVID, is the equivalent of the entire population of Hertfordshire, Bedfordshire, and Buckinghamshire put together. That's the amount of people that have been wiped out by COVID globally. If you take that into perspective, it starts to tell you the challenge that we're facing. But now we've got a vaccine that will help us move away from this pandemic. People are concerned, we understand. But there is also a social responsibility on all of us as individuals to work together to try and get out of this situation. And we are here to support you. We are AfroGP, Herts and Beds. We're a collective of doctors. We're not being paid to be here. Because we're here because we care about you. We don't want you to continue to suffer. We don't want to see our people die, which is why we're spending our time and we're sitting down here at this time trying to give you all the information you need so that you can make an informed decision. Thank you.
Thank you very much for our speakers. A few words from me. I mean, I think one of the things that we're hearing is that clearly we don't have all of the answers. The reality, though, is that if we wait to get all of the answers, we may not be around to get the answer. So what we have to think about is the fact that in the world that we live in, and every day and every minute of the day, we take risk. And we hope that we're taking calculated risk. And I think in this instance, what we do know is that we have something called COVID. And sorry, 1 second. We have something called COVID. We have something called COVID, and we also have something called a vaccine. So based on the information that we have available, we have to make a judgment. Is it worse to have the vaccine, or is it worse to have COVID? I think the data does seem to suggest that the potential impact of COVID, which has already been devastated, could be even more devastated over time. And if we're actually going to be protective of each other and protect our community, we do need to think about that. And I have to say, I made a note about long COVID, because actually, up until Pearl just mentioned it a moment ago, we hadn't heard anything about long COVID. But I can tell you, I work with some colleagues, and I can think of one colleague in particular who contracted COVID April 2020. And she's still now suffering and going to see a doctor on a very regular basis because of the continuing impact of long COVID, and she doesn't see where that's going to end. So I think we all have to make some informed choices around this. The purpose of this conversation today was to share the insight, the experience, the knowledge of our medics and the medics from our community, along with other professionals like Jim and Lynn. And I can see from the comments that people have found this helpful. It is not for me or I think anyone else to tell anyone what they have to do, but actually I think we really have to try and take some objective views of this. We have to look at the amount of misinformation that there is out there, and we have to think twice as to whether or not we're actually going to listen to reasoned and objective opinions, or we're going to focus on a lot of misinformation that there is out there. As a quick example, somebody sent me a message saying that in the US, there was some 23 women had a miscarriage after having had the COVID vaccination. There was no explanation as to why these women had the miscarriage. When I started looking into this, I understand that naturally, but up to 1 in 4 women miscarry all the time. So that's kind of thing that people who are wanting to think, oh, there must be something else, oh, there must be this kind of thing that we are saying that people are not to be trusted, and there are good reasons for that. But actually, I think the information that we've seen and the initial thing around this was that, oh, we're going to experiment with this vaccination in Africa, and therefore, of course, that's always has been happening in the past. But what we've seen in reality, that has not been the case. And actually, we have to come and start thinking about this realistically and thinking about this, as I think our speakers have said, in the best interest of our community and our families. And I think that's where I'd want to leave tonight. Let's go away, think about this positively. And we have a vaccination session has been put in the chat that's happening on Sunday. There's another one the following Sunday. So the one on Sunday is at the Hollowell Community Centre, as far as our conversation has been so far. The one the following Sunday is going to be at Stanborough Church Centre. And it's there to enable those people within that age category, as has been explained, who may not feel confident of going elsewhere, that they can come and have their vaccinations there. I believe some, if not all, of the doctors that you heard in the panel tonight will actually be there actually distributing the vaccines themselves. So this is where we're actually keeping in the community, because some of you will know that the motto of the Watford African Caribbean Association is together we can achieve. And I think this is what tonight has been about, trying to make sure we do it together. So what I'm now going to do is just to thank Lynn and the CCG colleagues who have partnered with us on this. Jim, I know, has been supportive throughout, but in particular, Pearl, Obi and Charles for giving up their time. It is what community is about. And actually, in Africa, we talk about it takes a village to raise a child. And of course, it takes a village to kind of create the community that we need. And we want to create that again, and we want to work together to make this happen. This is not the end of the story, I'm sure. And I'm sure we want to work with our doctors, work with our public health officials and others to try and make sure some of the inequities that have rightly been pointed out in this conversation are going to end tonight. It's not all going to end tonight, but actually we've got to go on that journey to end all of that. And that's what this association is about. And I hope you will join us in sort of making sure that the story from here on in will be one where it will be a positive experience for all of us. And I think that starts with, thinking seriously about having the vaccination. I think we had over 60 people who joined in this conversation tonight. Thank you all for joining in. This was only a value because you were a part of it. The association itself is only a value if you become a part of it. And in the chat, you'll see how you can get involved in what we're doing. Any final words from anyone else? Because I think we've taken liberty with your time, much more than we'd anticipated, but this is what this is all about. Pearl, were you going to say something?
Yeah, sorry. And the final word is I believe the council is aware that whether you have papers or not, whether you're documented or not, please come forward. It's for you. It's for everybody. So please don't stay at home and think, well, I don't have the papers. I'm not sure about X, Y, or Z, or immigration or this sort of thing. Please come forward and get your vaccine, because it's for us. This vaccine clinic is run by us, by Black doctors, and it's for our community. So please come forward. Thank you. That's what I wanted to say.
Thank you very much. We're all in this together. If you know people who might want to have a look at what was discussed tonight, we will make this information available. So once again, thank you all for joining us. Let's hope that we'll see a good few people turning up on the next two Sundays between 10 and 1 p.m. To get vaccinated. Thank you all and have a good evening. Can I ask our speakers if they're able to stay on for a few minutes? For everyone else, thank you and have a good evening.